Hello, everyone. This is Claire Sayer from MCOL, and I'd like to welcome you to our webinar event today. Our seminar speaker today is Bill McCain, Senior Vice President at the Gorman Health Group.
So the Pioneer ACO program is it's a demonstration program. It's not permanent. It operates under the authority granted to CMS to put together demonstration programs. It's not operating under the Shared Savings Authority of the Affordable Care Act. Agreements last up to 5 years, but with performance measured after the first couple of years to see if you can go on or not. And performance is quality cost, the efficiency equation, and compliance with the program. There's more reward and more risk than there is in the shared savings program, and crucial for our discussion today, it shifts to one of 3 different variants on capitation after the first 2 years. It was limited to experienced programs, those that already had experience with capitation. Also uniquely, beneficiaries can opt into these things by attestation. That means they can opt to join it, even if they have not been receiving their primary care from the physicians in the ACO in the past. And that sets it apart from the shared savings model. It uses the same quality measures, and they say it's not accepting new applicants now. Beneficiary alignment is prospective. You know who you're accountable for, but it's reconciled retrospectively because new patients are going to arrive every year during the course of the year, and others will leave for one reason or another. Physicians will join and leave, and so there has to be some way of reconciling, but at least you know the bulk of the patients you're responsible for at the beginning of the year, and this now has been carried over into the standard shared savings model as well. The alignment or the assignment is the word used in the Affordable Care Act. Alignment is the somewhat softer term that the Pioneer program uses, is based on primary care services, mostly from primary care physicians, although they recognize that some medicine subspecialties really provide a lot of primary care, maybe the definitive primary care source for many patients. So they tried to find a way of including them. The shared savings program, the permanent program, actually has gotten more inclusive by the time they worked out the final regs. The alignment is based on the plurality of evaluation and management charges, not visits, and they pick charges rather than visits as just a way of trying to minimize the likelihood of ties, whether somebody is in or out of the ACO's panel of patients. And it's based on 3 years' experience. Again, the opting out doesn't mean you're not in the ACO. It just means CMS can't share claim data. And the benefits are the same inside or outside the ACO, which makes it different from commercial ACOs, which are usually built on a PPO benefit platform where beneficiaries have a financial incentive, a benefit incentive to get their care from participating ACO physicians and hospitals rather than outside. That's not true in Medicare. Now, savings and losses in the program are based, as I say, calculated relative to a benchmark. The benchmark is not necessarily a measure of what fee-for-service costs would have been in the absence of the ACO's efforts. It's by design intended to be a little bit different from that. The benchmark, as I said, is one of the critical factors in this thing. If you're going to show savings, it's not relative to some unmeasurable event that didn't happen, which is the fee-for-service costs that would have been incurred if you weren't there. Rather, it's based on historical costs trended forward, and the assumption is that by trending, they're going to come out somewhere reasonable. The baseline is an average of 3 years, 2009, 10, and 11, 3 years claim data. Trended forward to 2011 claim dollars. They've tried to adjust the claim for beneficiary characteristics, age, sex, whether your initial Medicare eligibility was based on disability or not, just as a way of trying to get some risk adjustment into this thing. And then it'll be trended forward to 2012, 13, and 14. And I'm looking here just at the first 3 of the 5 years of the demonstration program, based on a mixed formula of the historical trends. The historical data is trended to 2011 using just the percentage trend for each of these cohorts, where the cohort represents a subset of Medicare beneficiaries based on age and sex and a couple other characteristics. ESRD is another one, but that's the only medical characteristic. Going forward, it's a blend of a growth rate, a percentage rate, and the annual fixed dollar increase in Medicare costs, again for the same matched cohorts, the same subsets of enrollment. But the notion is that if your benchmark, where you're starting out, is less than the national average fee-for-service cost, by using this approach, you'll actually go up a little bit faster than the national average percentage rate. And similarly, if you have a high cost history, you'll go up a little bit more slowly by blending this fixed dollar amount and a growth rate. In the Affordable Care Act, the formula that's laid out in the Act itself is entirely based on the a fixed dollar increase. So let's say that, again, if you start out with a benchmark of $700 and the national average is $800, and the average cost went up by 5% or $40 from one year to the next, you would have that $40 added to your $700 benchmark, so you would go up $740, which is more than a 5% increase. On the other hand, if your benchmark was based was $900, you would also have that $40 added to your benchmark, and so your increase from one year to the next would be from $900 to $940, less than a 5% increase. The goal is to give a little extra edge to people who are already a little more cost efficient than, or at least have a little lower cost for whatever reason, than the national average, and to not to reward a high cost participant with high average costs and therefore a high benchmark with the same percentage increase, because it would be a larger dollar increase. So that's probably a little bit too involved, but that's how it works. Going on to the next slide, the benchmark each year is trended forward from that baseline period of 2009, 2010, and 2011. However, the composition of the beneficiaries may change. As I said, the beneficiaries who are aligned with your ACO is reconciled every year. And so in recalculating the benchmark every year, they go back and look at the claims history of the people who are actually participating. So the period doesn't change. They're still measuring how you're doing in 2011 or 2012, 2013, 2014 versus this 3-year average going back to 2009 through 2011. But the composition of the people inside each of those little blocks is changing as the beneficiaries are changing. Again, it's a way of doing some sort of risk adjustment, so that if you're attracting riskier people over time, you're incorporating their claim history in the benchmark. So it's also adjusted for decedents who generated costs in the baseline period but do not appear in the current year's roster of patients. So CMS goes back and adds them in, and they also get added in, of course, in calculation of your current year's costs, and that's a way of avoiding omission of some very high-cost beneficiaries in calculating whether you're producing savings or not. Also, new to Medicare beneficiaries who had no claims in the baseline period still get added into this thing with a sort of a standardized rate. So there is an adjustment in there for both people who've died between the baseline period and the period you're being measured for, and also people who've been new to Medicare who've come in over that intervening period. As I mentioned earlier, the trends reflect a reference population. that has the same age and sex composition as your roster of beneficiaries, and age and sex for a large population, and the pioneers have to be at least 15,000 members. It's a fair predictor. It doesn't tell you everything you would want to know, but it's better than no adjuster at all. It also matches to the Medicare category, aged, disabled, or ESRD. And then also, for each beneficiary, claims in excess of the 99th percentile are discarded, so they just truncated at the 99th percentile, and that's the equivalent of a specific stop-loss coverage, which, again, is a risk adjuster. Now, ideally, the beneficiary would be the benchmark would be a good predictor of costs, what they would have been absent your efforts to improve efficiency. And CMS did a simulation. They took the 55 original pioneer applicants, from whom they selected the 32 finalists, and calculated their benchmarks based on 2004, 5, and 6 data, because they knew who the participating physicians were, so they could go back and identify who the beneficiaries aligned with that ACO would have been. And then they could look at how good a job that historical data did in predicting 2007, 8, and 9 costs. A good predictor would mean a small percentage difference between the benchmark and the actual cost. And if that were true, then if you did see a difference, you could be confident that most of that difference was being caused by something the ACO was doing, for better or worse. And here's what they found. As you can see, they're all over the place. And some of them went up over time, some went down over time. These are percentage changes, the percentage error of the benchmark versus actual. And so far I haven't seen an explanation of what happened or why they thought this happened. On average, and you can tell just by eyeballing this, on average they did okay. And then, the errors tend to offset each other. And the average error in each of the 3 years they looked at is pretty small. But the difficulty is that any individual ACO is not the average. And some of them, had they been participating in the program during the time period that was used for the simulation, would have experienced some significant apparent gains simply because of whatever is going on in the data, and others would have shown losses, again, just because of something happening in the data. And we don't know what that is at this point. But it's a challenge going forward, and it's something that if you're interested in capitation for ACOs, there are a lot of good reasons to look at capitation in an ACO. But the calculation of the benchmark and the validity of the benchmark as a predictor is a concern. And I think that's one of the things that we want to look at in the evaluation of the pioneer programs over time is, are they able to compensate for whatever is causing this statistical variation? So that's pitfall number one. There are a couple, but this is one of them.